In Chapter 1, we will focus on the basics you will need to perform well in critical situations. This chapter is broken into several portions to aid in your understanding. The first section is part of the patient approach. We will focus on the chain of survival and team dynamics. Advanced life support is performed on a continuum called the chain of survival. This chain is associated with decreased mortality in patients with sudden cardiac or respiratory events. There are a few basic steps. The first is prevention. This step focuses on the timely identification of a problem and the rapid employment of an appropriate action. Next is activation. This is activation of the emergency response system, which may include shouting for help, calling 911, or announcing the event over paging or intercom systems. Activation is followed by resuscitation, which is the delivery of high-quality chest compressions, ventilation, and timely defibrillation. Next, as an advanced cardiac life support provider, you will use techniques to establish an airway or administer medications. From here, post-event care begins, which is follow-up in a high-care setting or a hospital or transportation to an appropriate facility. Depending on your role, this may include transport to a local emergency department or transfer to a helicopter or higher care facility. The final stage is recovery, where healthcare providers facilitate rehabilitation and provide caregivers with resources and support. Together, these steps make up the chain of survival. This chain may change based on the location of the patient. The important thing to remember is that recognition, fast, appropriate response, and rapid defibrillation when necessary all facilitate the need for post-cardiac arrest care and transport. You will learn each step of this process during this course, and I'll introduce you to some key players. A patient is lying on the bed, appearing very ill. The nurse walks in to check on her, but is unable to arouse the patient. The nurse shakes the patient and performs a sternal rub, calling her name. The nurse walks quickly to the emergency pull station and presses the staff assist button. She checks breathing and pulse for less than 10 seconds and starts compressions. As you saw, the nurse walked into the room and the patient wasn't responding. She couldn't get her to wake up. For advanced cardiac life support, she knew she needed additional help, so she pushed the staff assist button.
Help! I need help!
She checked for pulse and breathing, but she couldn't find them. Then she started CPR.
What happened? Patient's unresponsive. No pulse.
I got the crash cart.
I got the bag. Okay, I'll take lead. Amy, you continue to record. Phil, I need you to get IV and meds and get the pads attached as soon as you can. Alan, switch with Morgan at our first 2-minute mark. Okay. All right, pads are attached. Let's pause for a rhythm check.
Looks like we're in asystole.
I agree, asystole. Let's go ahead, continue compressions.
I've got a line.
Line is in at 0910.
Okay, let's go ahead and get 1 milligram of epinephrine.
Drawing 1 milligram epinephrine. One milligram epinephrine in.
1 milligram epi in. It's been 2 minutes since our last rhythm check.
Okay, hold compressions. Go ahead and switch.
I show VTEC.
I agree, VTEC.
No pulse.
Continue compressions, man. Get ready to shock at 120 joules.
Charging at 120.
All right.
All clear.
Clear?
Cardiac arrest can be one of the most stressful situations you may encounter in healthcare or even on the street. The most important practice you can use while delivering this care is a good team dynamic. The best patient outcomes occur when a team runs like this one. These nurses are working quickly and effectively. The doctor demonstrated his role as a team lead and assigned tasks. These nurses are experienced and anticipated their roles in the cardiac arrest. The team leader is responsible for assembly and organization of the team, monitoring each team member's performance, performing advanced skills beyond the scope of the team members, and modeling exemplary behaviors. The team leader should also provide feedback and constructive critique to each team member as necessary. The team leader should remain calm. The lead is often a doctor, but may also be an experienced nurse or paramedic. Each scene is different, but typically the person with the most experience will take the leader role. There can only be one leader at a time, and that role may shift as the patient is transferred or care progresses.
Alan, try to go a little deeper on those compressions. You need a break, you switch to somebody?
I'm okay for now. Let's switch at the next pause.
Okay, Alan and Margaret, switch to the next break. How long till our 2 minute mark?
We hit 2 minutes and another 30 seconds. It's been almost 4 minutes since our last Debbie.
Okay, let me know when we hit the 2 minutes. Phil, let's go ahead and get another milligram of epinephrine ready.
I'll get the epi ready.
We'll administer during the next switch.
The team members should follow the leader's instructions. Their job is to understand their role, perform the tasks assigned, and understand the ACLS algorithms, which you are learning now. Their job is to contribute to the success of the team. There are a couple of key things to remember about great team dynamics. Team members should use closed-loop communications. You've seen that in the video. The leader gives an instruction and it is repeated back to the team member. Once confirmed, the team member carries out the instruction. We also saw this team establish clear roles and responsibilities. Each member announced what they were going to do, and the leader assigned tasks that had not been completed or confirmed the roles of nurses who had already started helping. The leader avoids giving more than one task to a person to prevent confusion. The team members know to speak out if they need assistance or to trade roles. This cardiac arrest is running well. Margaret knew her team would come quickly. They have a lot of respect for each other, and they knew which roles need to be accomplished since they were all ACLS certified. The doctor is always great. He is the team leader, but he doesn't yell and he doesn't panic. The best leaders are calm and respectful to their team members. They try to communicate as they go, so everyone is on board. This helps them to make sure the person documenting gets all the information they need and that they don't miss actions they need to help the patient survive. You've seen a great example of using team dynamics during a cardiac arrest. Here are the 4 key takeaways. Always have a team lead. Understand each of the roles and responsibilities. Use closed-loop communications and provide constructive feedback. One of the key factors for a successful resuscitation is using a systematic approach. This includes basic life support and your primary and secondary assessments. The goal is to quickly assess and treat the patient so the patient has the best chance of getting ROSC, or return of spontaneous circulation. The first step in this systematic approach is scene safety. The rescuer should always perform this step, regardless of their environment. Common concerns include fire or electrical hazards, physical concerns like traffic safety or flooding, and other concerns like dangerous chemicals or biohazards. Hospitals can have hidden threats like infectious diseases or the need for personal protective equipment to prevent possible exposure to bodily fluids. Always use appropriate personal protective equipment and check the scene for safety. You should visually inspect the patient if you can see them. Once you have confirmed scene safety, you should approach and confirm your initial impression. Assess level of consciousness by speaking loudly and touching the patient firmly. Shaking isn't always advisable if the patient suffered a potential trauma. Try rubbing the patient's sternum. In an unconscious patient, you will begin basic life support assessment for respirations and pulse for no longer than 10 seconds. The components of the BLS can be easily remembered using the mnemonic doctor's ABCD. Assess for danger and responsiveness, shout for help, assess airway and breathing while simultaneously assessing for pulse. As soon as an AD is available, defibrillate if necessary. Basic life support is an important part of advanced life support efforts. Without good foundational BLS, the patient is unlikely to survive. Let's review the components of BLS. Start with the primary survey. Check for breathing and pulse. If the pulse and breathing is normal, continue monitoring until EMS arrives, the patient is transported, or the patient deteriorates. If the patient has no breathing or pulse, you should immediately start CPR. Use an AED or defibrillator as soon as possible and shock if the rhythm indicates a need. You will learn more about rhythm identification later in this course. Always immediately resume compressions after shocking the patient. If the patient has a pulse but demonstrates abnormal breathing, you should deliver rescue breaths. This is one breath every 5 to 6 seconds. Make sure to count out loud. Many rescuers don't realize how long 5 or 6 seconds really is. Let's review the basic components of BLS. It is vital you perform these steps effectively. Call for help.
I need some help in here.
Check pulse and breathing for less than 10 seconds. When in doubt, don't delay. It is better to provide unnecessary CPR than to delay chest compressions. Make sure the patient is on a firm surface, using a backboard if available, and if placing the backboard doesn't delay compressions. Locate the sternum by palpating the chest with 2 fingers. You want to focus your pressure on the lower 2/3 of the sternum. Place the heel of one hand over the other and keep your arm straight. Your shoulders should be directly over your hands so you can use the weight of your body to increase the depth of your compressions. You should compress between 2 to 2.4 inches or 5 to 6 centimeters in adults. Allow the chest to have complete recoil with no weight on the chest between compressions. You should perform between 100 and 120 compressions per minute. In one rescue or CPR, you will perform 30 compressions followed by 2 breaths. Try to minimize interruptions. Once a second person arrives, switch roles as soon as possible. One person will compress and the other will perform rescue breaths. If AED is available, place the pads on the patient as soon as possible and follow the instructions from the AED. Rescuers should switch every 2 minutes to allow rest for the compressor. Follow the 30 compressions to 2 breaths ratio.
Hey, you okay? Are you okay? I need some help in here. Call 911 and get an AED. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. 1, 2, 5, 6, 7, 8, 9, 10. 2, 3.
Apply pads to patient's bare chest. Plug in pad connector next to flashing light. In CPR. Shock advised. Charges. Stay clear of patient.
All clear?
Deliver shock now. Press the orange shock deliver.
1, 2,
Begin CPR.
Defibrillation is the delivery of an electric shock, which is an attempt to reset the heart to a normal rhythm. Early defibrillation has been shown to significantly improve patient outcomes. There are several different brands and types of defibrillators. AEDs stand for automated external defibrillators. AEDs are capable of recognizing and cardioverting dangerous arrhythmias without needing interpretation from the medical provider. They usually deliver a set rate of electricity for every shock. Defibrillators are usually manually read by the rescuers, but are capable of delivering more precise energy doses. Either can be used in an emergent situation, but defibrillators are preferred by advanced life support teams. When placing AED or defibrillator pads, follow the instructions on the pad. Most pads are placed on the right upper chest and either on the back or left side of the patient. Avoid oxygen lines and implanted devices under the skin, as well as medication patches, which should be removed. Ensure the skin is dry before placing the pads and make sure the patient isn't submerged in water. Don't stop CPR until the pads are on the patient and the defibrillator or AED is powered on. Once the device is ready to analyze the rhythm or a rhythm is displayed on the screen, the rescuer should stop CPR. Instruct all bystanders not to touch the patient during analyzing. An AED will alert you to shock the patient. Follow the verbal instructions. If a rescuer notes a shockable rhythm using a defibrillator, or if the AED instructs the rescuer to clear the patient, he or she should shout "clear"
All clear?
and do a visual inspection to make sure no one is touching the patient. If needed, press the shock button and immediately resume CPR.
Deliver shock now. Press the orange shock delivered.
The AED will instruct the rescuer when to stop again for the next rhythm check.
Apply pads to patient's bare chest. Plug in pad connector next to flashing light. Analyzing heart rhythm. Do not touch the patient. Shock advised. Charges. Stay clear of patient.
All clear?
Deliver shock now. Press the orange shock deliver. Begin CPR.
Now that you've had a chance to review basic life support and what to do in an emergency, let's talk about the primary assessment. This assessment is often known as the ABCDs of patient care and starts with airway. Patients who are capable of having a smooth conversation are not typically in respiratory distress. However, you should check for physical signs of distress like an increased rate of breathing, use of accessory muscles or airway sounds like wheezing or stridor, which is a high-pitched noise often associated with a closing airway. Check to ensure the patient does not have any external injuries or foreign bodies. This includes looking for increased secretions for substances like vomit, which may inhibit the airway. Unconscious patients may not be able to protect their airway, meaning their tongue may fall into the back of their throat, obstructing it. Perform the head tilt chin lift maneuver to manually open the airway. If there is any suspicion of trauma, use a jaw thrust to open the airway instead, to prevent movement of the spinal cord. You may also choose to insert an airway adjunct, such as an oropharyngeal or nasopharyngeal airway, to ensure patency. The oropharyngeal airway is only for patients who do not have a gag reflex. It is measured using the corner of the mouth down to the corner of the jaw like this. It is inserted with the curve going towards the nose until about halfway in the mouth, then twisted 180 degrees downward. This holds the tongue against the floor of the mouth, keeping it out of the airway. The nasal airway is for patients who are unconscious but have a gag reflex. They are measured from the side of the nair to the tragus of the ear. The opening is inserted towards the septum, usually on the right side of the nose after lubricating with a water-soluble jelly. Not all patients will benefit from a nasal airway. It should be avoided in patients who have had facial trauma. Breathing is the next step of the primary assessment. Once the airway is open, breathing should happen spontaneously. Check for signs and symptoms of inadequate respirations like cyanosis or decreased oxygen saturation if you have tools capable of measuring pulse oximetry. Capnography is the gold standard for cardiac arrest, which allows rescuers to assess end-tidal CO2. The appropriate range for end-tidal measurements is 35 to 45 millimeters of mercury. If the patient is not breathing adequately on their own, assisted ventilation is at a rate of 1 breath every 5 to 6 seconds. Insertion of an advanced airway may be indicated in cardiac arrest patients, but CPR should never be delayed for the purpose of airway insertion. If chest rise is visible while using the bag valve mask, insertion of an advanced airway should wait until ROSC has been achieved or a provider capable of placing an airway in less than 10 seconds has arrived. This minimizes the interruptions in CPR. The third step in the primary assessment is circulation. This is the easiest to measure using capnography, which will remain above 35 millimeters of mercury if adequate CPR is being performed. Other signs of perfusion include a capillary refill of less than 2 seconds in warm environments or blood pressure. At this point, rescuers should place at least one large bore IV and/or intraosseous device to administer medications as necessary. Advanced life support providers can initiate drug therapies according to resuscitation algorithms. This step also includes the AED device and possibly identification and treatment of unstable arrhythmias. The fourth step of the primary assessment is disability. The acronym AVPU is frequently used by providers to indicate the patient is either alert, arousable to verbal stimulation, arousable to painful stimulation, or is unconscious. It is generally assumed that a person in cardiac arrest is unresponsive and has a Glasgow Coma scale of 3, which is the lowest score on the scale. The scale measures eye opening, verbal response, and motor response with a score of 3 to 15. A patient who scores a 15 is considered to have no deficits, while a patient who scores lower than an 8 is considered to have severe deficits, often requiring CPR or rescue breathing. The final step in the primary assessment is exposure, which includes removal of the patient's clothing and full physical examination. The provider should carefully inspect the patient for any signs of injury, especially injuries which may cause hemorrhage, which is the leading cause of death in trauma patients. Check for the possession of a medical alert bracelet, necklaces, or cards. It is important to note that all clothing should be removed for inspection, but the patient should be kept warm. Hypothermia can compound the effects of hemorrhage and is detrimental to the patient. Once this step is completed, the providers will begin their secondary assessment, usually after ROSC has been achieved. The secondary assessment begins with collecting more information. Providers often use SAMPLE to determine some key findings. SAMPLE stands for signs and symptoms leading up to the event. Allergies to medications, including over-the-counter and herbal remedies, past medical conditions, the last meal or beverage, and events leading up to the medical emergency. Later, as time allows, providers will also assess pain if the patient is awake. Every cardiac arrest is preceded by something, though rescuers may never have a definitive answer to what caused the arrest. It is important to determine what may have happened to prevent the arrest from happening again in patients who have achieved ROSC, or to perform life-saving measures in patients who are still in cardiac arrest. An easy way to remember common causes of cardiac arrest is to categorize them as H's and T's. H's may include things like hypovolemia, hypoxia, or too little oxygen, hydrogen ion elevation, which is acidemia, hypo or hypokalemia, or hypothermia. T's include toxins, which may include drug overdoses, tamponade, or tension pneumothorax, which must be quickly identified and treated, and thrombosis, which is commonly seen in acute coronary syndrome, stroke, or pulmonary embolism. Identifying the factors likely to cause cardiac arrest may not mean that ROSC is possible, but it does help rescuers perform the right interventions in a timely fashion. It is also in this stage that testing may begin, including electrocardiograms, laboratory studies, and imaging as necessary.